Welcome to today's PerfectServe sponsored webinar, Solving the Complexities of Clinical Communication. My name is Vicki and I will be your operator for today's call. We have just a few announcements before we begin. Please direct your attention to your screen as we briefly go through how today's presentation will operate. Please note that you may need to zoom in or out in your browser to see everything. In the center of your screen, you'll see a box containing today's slides. They will advance automatically throughout the presentation. To the right of the slides is the Q&A box where you can submit a question at any time. Questions will be addressed during the Q&A portion at the end of the presentation. To the left of the slides, you'll see a resource list with a PDF of today's slides and a few other helpful resources, including the webcast help icon if you need any technical assistance. And finally, here is the Twitter feed for today's webinar. Tweet along with us using hashtag #PSWebcast. If you're on the phone line but experiencing any technical difficulties accessing the web portion, please send an email to webinars@perfectserve.net. At this time, all participants are in a listen-only mode. At the conclusion of today's event, we ask that you complete a short survey that will appear on a separate browser window. And now, I'd like to turn things over to Carrie Ballman, the Vice President of Marketing Communications at PerfectServe, Inc.
Hello, everyone, and thank you for joining today's call. This is the last of our three-part nursing leadership series. We've had some strong presenters throughout the series, and we've had a lot of good takeaways for our audience members. And part 3 today is maybe no different. I'm pleased to announce today's presenter, Julie Mills. Julie is the Senior Manager of Sales Support at PerfectServe. She has 14 years of experience in informatics, and she also has served our country as a captain in the United States Air Force Nurse Corps. Julie currently specializes in evaluating communication complexities, identifying strategic opportunities within an organization, and designing solutions for client success. Julie, go ahead and take it away.
Thanks, Carrie. Our learning objectives for today's talk are to define the current communications landscape in today's healthcare market, identify and understand the complexities of clinical workflows, particularly with the physician population, and the key requirements to solving streamlined communications across the care continuum. There's a common saying that in order to solve a problem, you must first seek to understand. Einstein says of an hour, he'd spend 55 minutes thinking or seeking to understand, and 5 minutes dwelling on solutions. While I'm not going to take quite that long, let's first discuss the current landscape and gain understanding of the complexities. Mobile providers work across many different care settings and are part of multiple teams. The primary center of work for the provider is his or her practice, and communication is driven by voice, mobile app, and web, by and between many different types of clinicians and patients. When we combine multiple practice sites covering multiple hospitals, you can see why it's so difficult to coordinate care when communication between all these constituents is so complex. To truly achieve better care coordination and the efficiencies and revenue that result, a communications platform is needed that's sophisticated enough to be able to connect all these clinicians in multiple care settings. The outpatient area is expansive and the heart of the physician practices, patients, and all of the supporting organizations for physicians and patients, such as pharmacies and outpatient therapy offices. The communication processes in each of these entities may be vastly different as their needs are different. Take a physician's practice, for example. There are several types of communications taking place. Patients, pharmacies, labs, hospitals, and other community providers are all calling. Each of these communications may need to be handled differently in order to be most efficient. Large practices may institute their own call center as volumes rise and more people are needed to filter and route communications. Labs may have critical results with timed protocols, and hospital staff may be reporting an acute change in patient status, both of which require timely interactions. Internal staff, such as medical assistants and nurses, administrators, medical records, and front office personnel, need to communicate with each other as well as reach their providers when they are not in the office. Many of these communications involve patient care, and it's important those communications be handled in a secure manner. Many practices also employ an answering service, which may operate and communicate with providers in a number of ways. Often these interactions are prolonged by the intermediary and may include calls back to the service or manual tracking of messages, even a lack of ability to log responsiveness. The number of healthcare system employed groups continues to rise, and the size of medical group practices seems to be increasing as smaller groups merge to share cost and increase profitability. Employed groups are often governed by a corporate entity and may depend on that administration to make decisions related to communication technologies. Lastly, medical group practices may have an affiliation with multiple facilities, often in different healthcare systems, which means different communication protocols or technologies. This creates issues with adoption, as streamlining communications is imperative for operational efficiency in this arena. The post-acute sector shares some of the same realities of both the outpatient and inpatient world. There is a constant need of beds for those transitioning from the acute hospitals, and the requirements of insurance companies or payers for those still in residence. Case management or care coordinators and social work manage a large piece of these vital transitions and often need to communicate with the facility administrators or accepting physicians in a timely manner. Likewise, the discharging provider would often like to give report in real time, but the inability to communicate effectively impedes this handoff from occurring. The post-acute community is also known for having fewer technology options available. In many cases, providers create processes to not have to call back, as these calls may not be handled in a timely manner. Many of you have probably seen a sheet just like this. This is an example of an honest effort on the part of the hospital staff to follow physician contact preference rules. You can see the device numbers are visible here for anyone to see or jot down. And on the right, we have special instructions about how each doctor wants to be contacted. The problem with these sheets is that they aren't updated in real time, and eventually, as changes are made, they become harder and harder to follow. A few examples are scratched out numbers, bad handwriting, or things that are difficult to read. Examples like beep and then call cell first, but no instruction on what to do second, or do not call on Wednesday with no regard as to what to do on Wednesday. Even do not call at home, but there are home numbers listed. The acute care space is riddled with communication complexities and thus breakdowns. Many of the solutions we see in the market are designed to bridge the communications gap for hospitals, but don't reach outside the four walls into physician practices or systems located on separate campuses. When examining the acute care space, it's imperative to acknowledge the vastness of interactions that occur. Nurses and other care team members, those care team personnel to hundreds and even thousands of providers, that medical staff to the staff at a sister facility with perhaps a higher level of care, the transfer center in between, and the primary care providers in the community. Inside the four walls is only the first step, and while it's a necessary and important one, the continuum of patient care demands that solutions span much further. As healthcare delivery models change along with reimbursement, it's imperative that coordination of care be streamlined and efficient across all of these settings. The effort to keep patients out of the acute space when possible and shortening stays in the hospital when able demands a robust process of outpatient to inpatient communications with both providers and care participants. instead of focusing on the medical staff of a single hospital or who is employed versus independent. Providers may additionally look to ACO participants for consults and referrals. This is an actual study of a 528-bed hospital and their communications process that nurses in one unit experience when reaching out to providers. Each shape represents a different step, a handoff, or a transition, and each of these steps, handoffs, and transitions all introduce risk and communication variability that can potentially lead to breakdown. You can see it somewhat of an eye chart, but the message really above all is that there is a lot going on that all care team members have to go through in order to effectively communicate. So a poll question at this point for you to answer: how often do staff struggle to find the correct covering provider, leading to wasted time? And we'll pause and give you just a couple of seconds to respond to this question. Now let's examine the results. 100% of you said that it's a daily battle to figure out who the correct covering provider is. And I think for all of us that are clinicians, we know that to be true and one of our most frustrating parts of work. Now that we know the landscape of communication, let's review key components to consider in a communication cycle. Let's start with initiation. When examining methods of initiating a call or message, there are many options that are available. Those patients or practitioners in the community likely choose a phone, whether it be mobile, home, work, or hospital, to reach out to someone. Nurses and other ancillary members in the facility may have additional options, a VoIP phone, or perhaps a messaging service available via their workstation. The workstations may be at a desk, at the bedside, or on wheels. Additionally, a personal mobile phone may be used to call or text a provider's direct cell. The reality of healthcare today is that there are fragmented technologies, point solutions, if you will, that exist to solve a unique situation. But these solutions aren't comprehensive enough to solve the entire spectrum of clinical communication. This leaves caregivers functioning in a world of disparate systems, many of which may not be updated and current. So there's continued frustration and the continued quest to solve the communications issue. Point solutions have tended to be offered in one of four areas: nursing communications with vendors such as Volt and Vocera and a myriad of other VoIP vendors, each with their associated middleware such as Extension and Connexall. The relatively recent need to comply with HIPAA regulations has spawned a multitude of secure messaging vendors in a rapidly commoditized secure messaging space. And lastly is the physician communication piece, where fewer vendors have attempted to deliver a comprehensive solution. However, it's commonly the most complex and essential piece of the puzzle. The method of initiating a communication may vary based on a few factors. First, what available technology exists currently? Many people no longer have home phones or even phone books. In the hospital, there may be a communication solution in place that allows or is a standard for communications. It may be used consistently, but if not found to be comprehensive, often other methods of communication are used. The urgency of a message may drive one to call as opposed to send a message. If immediate feedback or more dialogue is needed in order to determine next steps, calls are preferred. Likewise, many providers can't make themselves immediately available for non-urgent communications, so text messaging is preferred. Convenience is a factor as well. Many find it easier to have a conversation while multitasking as opposed to texting. For nurses with mobile phones, they can call on the go as opposed to being at a workstation to message. Others simply prefer to discuss or send text messages. In addition to initiation, there is the process. And in reality, most communications must start with process before ever reaching initiation. So often people aren't sure who to contact, and there's an extensive process that takes place to determine who to reach before ever engaging the technology or the initiation step. I'd like to challenge that standard and allow you to see a world where the pre-work is removed and the process is built into the cycle in a more meaningful and effective manner. This is reality. Lists, notes, Rolodexes, all with outdated information, acronyms, and differences. Every group on the medical staff and beyond, and every provider in that group has a process and a preference. The expectation is for nurses and care team members to know the process and respect the preference. To a nurse covering 8 patients, each with 4 to 5 providers, it's burdensome to keep up with who is part of what and how. When you take all of this and add on the layer of how do I reach out to my fellow nurses on another unit, and who's assigned to whom, and how do I contact the respiratory therapist versus the physical therapist, you can see that there is significant complexity just in the process. PerfectServe commissioned a Nielsen survey of 1,000 healthcare members, both inpatient and outpatient, providers, administrators, care team members, and case managers, and the results displayed here are most likely not surprising to anyone who's listening. A few key results I'll discuss. First, 97% note that the extended care team outside of the 4 walls are also critical. 70% are using disparate systems, and 50% of the time they don't know who they need to contact, which is really at the heart of being able to communicate. The quote process or pre-work being done leads to 50% of us not knowing who we need to reach at any given time. Additionally, the EMR has not been widely adopted for communications. When looking at workflows, it's important to understand the innate variances. Let's examine nursing assignments. The patient census and acuity is evaluated and assignments made. Thus, there's a direct nurse-to-patient assignment. With ancillary departments, respiratory and physical therapy, for instance, there may be more of a unit or department coverage model, even an entire floor or zone. Often, other team members are calling shared pagers or phones to reach the covering therapist without knowing who's actually carrying that device at any moment in time. In care team to care team communications, the key factor is availability. Staff may reach out to a role, perhaps the 4 West charge nurse, and the phone may ring and ring without answer. Obviously, that person is not available at the moment, and there's no intelligence built in, so the caller is forced to wait and try again later. In some solutions, the role doesn't tell you who's currently covering, so you're not sure who isn't answering in order to know the next person to move on. This is where real-time updates come into the picture. Imagine you're going into isolation, and you can click a button on your phone that lets the caller know you're unavailable and escalates the call to another nurse or therapist. Or perhaps if the 4 West charge nurse doesn't answer, the call is automatically pulled back and you're redirected to a backup person or phone. Another reality of care team workflows is staffing based on your unit or department census and the needs of the house. You may not end up with as many personnel as planned. The ability to adjust assignments in real time that are reflected throughout the house is important. Physician and advanced practice provider workflows are significantly different than care team processes. When consulting with different provider groups, we find dozens of ways to accommodate the same workflow, thus the need for tremendous flexibility when designing a solution. It's not as simple as being available or not available. Rather, we have to consider several factors. The originating role in that, is this a patient, another physician, or perhaps a nurse? I may want to ask different questions or receive the communication differently depending on who's reaching out. If I operate in multiple facilities, location may drive different workflows and schedules by site. On a more granular level, if I'm a surgeon and the OR is calling, I might want to receive those calls more directly. Some provider coverage models are determined by choosing patients at the beginning of the shift each day. There's no predictable coverage model, making it difficult to know who to reach at any given time. By integrating the group's patient list, we can route to the correct covering provider by asking for the patient's name. Urgency is vital when determining if it's a critical result or a routine consult at 2 a.m. that could be held until the morning. These should be handled, obviously, in very different manners. The reason for the communication, such as a new admission, which may lead to a schedule, or is it about an inpatient, in which case it may lead to one of 8 rounders that could currently be covering in that group. The date and the time are vital when thinking about day versus night coverage. And of course, the schedules are always an integral part to determining who to contact. Many solutions may stop there, and in most cases, there are still considerations that need to be evaluated. This is where status comes in. I'm on call, but I'm in the OR. When a nurse reaches out, I can't respond, and the circulating nurse may have my device, but is busy doing counts or tending to needs in the room, so there's no response. In many cases, there are subsequent communications sent as the caller is uncertain of the status of the message. There's also no automatic escalation process to redirect the caller, so they're left being unsure as to the next step. Imagine a world where you're notified that the provider is currently in the OR and asked if your message is urgent or routine. If you say urgent, it can route to a backup provider or perhaps ring the phone. If routine, a message can be left and you don't anticipate a callback in the near future. In addition to workflow considerations, there are varied coverage models that groups may adopt. Some providers cover their own patients, those that they see in the office, for instance, or ones they admitted, and we refer to that as each takes own. During daytime hours, care team members know to reach out to this provider. Of course, they may be on vacation or sick, so it's important that there are considerations in the routing. Another common model is to have one person from the group cover all calls for the practice, so there's one on-call person that changes daily. Finally, there's a patient-centered routing setup that I mentioned previously, where patients are assigned at the beginning of the shift to the currently working group of rounders. And tomorrow, there may be a different set of rounders covering a different set of patients. This is common in large hospitalist groups or internal medicine and pediatrics residency programs. Other important models are team coverage, where there may be a physician, a PA or nurse practitioner, or other provider all covering a set of patients. They may need to all get the communication, or one may field the messages and distribute as appropriate. Unassigned ER call is common and provides coverage for those coming into the emergency department not currently being covered by a specialist and in need of one. These schedules are usually managed by the hospital, not a particular practice, and are a shared responsibility. They're also a source of many communication breakdowns, as group coverages may change and the hospital doesn't receive the update. Consults and admissions have separate coverage models in many practices, so it's important to consider the reason for the communication prior to determining who is covering. Lastly, team alerts are those instances where we need to quickly mobilize a group of people for a specific reason. These alerts may be a team that's entirely internal, like a rapid response or a code blue, or a mix of internal and external, like a code stroke team. Different schedules and departments are included, some responsible for responding and some as FYI members, adding a layer of complexity to the communication. It's imperative that the covering providers acknowledge these communications quickly and that there be a process to notify a backup provider in the event that key personnel don't respond, like the on-call neurologist for the stroke team. Reporting around response times is also an added necessity for these events. A second poll question for you. How are your codes to internal and external providers handled, such as a code STEMI, or stroke. Please review the options, and again, we'll give you a little time to respond. Now let's review your results. Here we see some differences, which is always exciting. So it looks like 2/3 of you have an operator that's involved in the center of these communications. And maybe there's a page that's sent out and there's a manual process that they call back and confirm receipt. There's probably also a manual or human-centric escalation process to that. And the other 1/3 of you have just a mass texter page that's sent to a particular group, which may hit pagers for people who are not actually responsible at that moment in time. And these are common workflows that we see each and every day. The tools currently available are insufficient to address the complexity seen in clinical communication processes. And I'm sure all of you have all of these tools in your hospitals currently. Call centers, overhead paging, paper directories or web directories, 3-ring binders. There's a myriad of different ways that we handle communications. But they all fail to address the complexity, and that explains the continued breakdown and communication failures that we all experience. So lastly, let's consider the recipient of the communication. I mentioned the availability of the recipient at each moment in time, and because situations in healthcare are ever-changing, the ability to update one's status on the fly is imperative. But it's not enough to say I'm busy or unavailable. Rather, there have to be elements of managing expectations, as well as the ability to dynamically redirect to a new process. As with initiating communications, there are many modes of receiving them, and while providers still carry pagers, whether out of necessity or preference, there are some with standard cell phones that don't have access to apps. Others use a smartphone. There are also the VoIP phones, shared devices, and home desk and office phones. All of these devices drive the delivery of the communication, which may vary based on all of the factors we discussed earlier: urgency, reason, location or role, and so on. Solutions must accommodate these variations in order to bring holistic adoption. There's also HIPAA compliance to be considered, and it's become a hot topic over the past several years as we're seeing more incidents related to protected information exposure. As there are a variety of devices being used to receive information, solutions must address those with pagers and SMS text, not just the secure messaging text application. Organizations must look at communications routing through a variety of sources, not just nurses to physicians or nurses to other care team members. The graph on the right is an example of a hospital using PerfectServe and the breakdown of communication devices used to initiate and receive messages. While secure text is encouraged, it's unrealistic to think it's a comprehensive solution. Analytics like this bring a measure of accountability and, more importantly, auditability to the organization. As texting becomes more prevalent, it becomes imperative to see read receipts and have records of communications. JCAHO also recently approved the ability to text orders via secure communication tools, but there are additional requirements, such as the ability to see read receipts and audibility. The number of secure texting applications have exploded into the market with well over 100 different vendors. And they were designed to create this concern, but without addressing other workflow considerations and complexities, they experience low adoption. There are currently many IT organizations that are using secure message on a temporary basis while seeking more strategic, comprehensive solutions. So finally, solving the complexities around clinical communications. There are a couple of key factors that we need to examine, and let's just discuss them one by one. First a poll question. How comprehensive is your communications solution? And please review these 4 options and let us know from your perspective, based on what you have today, how comprehensive, based on the ability to communicate with other care team members, your physician staff, how comprehensive is that solution? And let's examine those results together. 100% of you said we don't have a comprehensive solution. And my guess would be that maybe you have some sort of solution that addresses certain types of communications or small areas of communication, but you realize that it's not a comprehensive solution that can adequately meet your needs. So solving the complexities, clinical communication solutions must be as comprehensive as the communication pathways themselves. Adopting a point solution to address nursing communications isn't adequate when the most complex communications nurses encounter are those to their physician colleagues. The technology must be capable of addressing the needs of a single hospital, a multi-site system, and reach into outpatient practices and care settings. Advanced directory capabilities bring the opportunity to coordinate care based on facility, group, or ACOs with the appropriate workflow processes built into each arena. Groups operating in multiple hospitals or care settings must have one standardized way to filter and direct their communications with efficiencies greater than routing calls to an office or answering service. Most importantly, the ability to generate real-time updates when patients present to the emergency department, are discharged home, or have critical results are essential to timely coordination of care. Imagine your office is securely notified when a patient is discharged from the ED or the hospital, and you have the opportunity to proactively schedule their follow-up appointment. It can happen. Solutions must provide a standardized way to communicate that accounts for present-day technology. Whether I pick up the phone for an urgent call, send a secure text via my workstation on wheels, or launch the secure application on my hospital provision smartphone, I'm able to access the solution, ensuring that I'm routed appropriately. Gone are the days of referencing binders, Rolodexes, and schedules, or Post-it notes taped to the wall or desk. All that is required is that I access the solution and follow the process. Whether you request by name, role, or specialty, the workflows, schedules, and status are included. Providers and administrators have real-time access to updates, so reaching the right provider has never been more streamlined. The goal is simple. Remove the variability, remove the handoffs and touch points that introduce risk and opportunities for communication breakdown. Initiate the communication in the manner you wish and let the process connect you to the correct covering provider for your clinical situation at any moment in time. And you can see in this graphic, this is a post-implementation look at that same 528-bed hospital and the streamlined process that comes from implementing a comprehensive solution. The key to making the process work is dynamic, intelligent routing. It takes more than a schedule and a phone list, more than an operator referencing a schedule and a phone list. Solutions require the ability to search in several ways, and regardless of how you search, the incorporation of the required workflow routing. We know that our day-to-day tasks are ever-changing, so the ability to make real-time web or mobile updates to coverages, schedules, or patient assignments is crucial to success. Based on the clinical situation or your availability, messages may need to be held until the morning or until you finish your meeting or procedure. Additionally, how you receive those messages may vary, and it's vital that the technology be as flexible as your needs require. So this is a hospitalist schedule, and it's a rather complex hospitalist schedule, but this is an actual real live client that is using PerfectServe today and their schedule pre-implementation. And this schedule is really for a single week of time. There are several facilities that are listed. Each facility has a different coverage team. The list of docs next to the facility notes which rounders will be covering. The inpatient floor calls will be covered by these rounders according to patient-centered routing, determined by a patient doc assignment established each and every morning. Each facility has separate rules for ER new admission calls, and these do not follow the patient-centered logic, but go to a dedicated doctor. Larger facilities also have rules for certain areas, such as the CDOU, as seen here, and these also go directly to a physician covering that area, which is a different process. All of these rules are divided among multiple shifts throughout the day and night. At night, the patient-centered logic steps stop, and a specific doctor is on call for floor calls. Some of the staff filling schedule slots are PAs, not physicians, and there are notes about which physicians are on vacation. So we can understand how this can be misinterpreted at times. This diagram shows the workflow process being mapped out and all of its intricacies for every moment in time and every clinical scenario. We established this sort of diagram after a consultation with the group, and we design it based on their ideal practice, reflecting considerations such as facility, time of day, department, patient, and role. And you can see all of these things listed here. While this process may be complex, this is the experience of the initiator. It's simple and elegant. So while there's a lot happening behind the scenes and there are a lot of different potential situations, when a solution is engaged, we find a streamlined, simplistic process. All of these communication-driven workflows, including schedules, work group rules, group and team mobilization requirements, and escalation paths, can be designed into a platform. And when the need for communication occurs for any particular situation at any particular time, PerfectServe can automatically analyze the variables and determine the appropriate routing to the right physician or care team member. This results in real-time, accurate, dynamic communication routing. The need for manually maintained on-call schedules, Rolodexes, and lists is eliminated, and with them the potential for delays and breakdowns in communication that negatively affects patient care. For true care team collaboration to occur, these disparate technologies must consolidate into a solution that can seamlessly deliver all of the pieces. Whether it be a native platform or an integration where all of the pieces are delivered through one technology, the end user experience should be seamless and coordinated. As the market of clinical communications and care team collaboration expands, the solutions in the space will need to more tightly align to provide a more streamlined experience for care team personnel. While each technology in healthcare has their unique purpose, such as the EMR, the more compatible they become with other systems, the more effective coordination of care will be. Imagine a world where you launch the EMR, review a patient's chart, and want to discuss with the covering cardiologist that day. Imagine clicking a link for the cardiologist within the EMR, and it references that provider's group workflow processes, reviews their schedules, and monitors their momentary status to direct you to the correct provider. You simply type your message, the patient's information is pulled from the EMR and is securely routed to the recipient based on their contact preference in that moment. It can happen. Key pieces of routing may come from other systems, like the patient information for a group, or notifying a primary care provider that a patient has been discharged from the emergency department and requires follow-up in 2 days. The ability to deliver these features is possible due to an open architecture which allows for information exchange via HL7 or a RESTful API. In simple terms, we can accept information from other systems, the EMR and nurse call systems, for example, and route them to the correct care team member or provider at that moment based on their real-time status and delivery preference. While doing the work to send the message may seem like winning the battle, it's imperative that there's up-to-date message acknowledgement with related logging and analytics. If I send a message to a nurse regarding a patient request and she never reads the message, what's next? Where does it go? And who follows up? If I send a physician a routine consult, how do I confirm the message was received? What if 24 hours passes and the patient isn't seen? Is there a record of the process? If a code STEMI is called and the interventionalist on call doesn't read the message, is there a human being watching the clock to call again? All of these situations are very real to us and happen daily. Solving the complexities of clinical communication doesn't end with sending the message. You have to ensure it's received, acknowledged. The solution must have a notification process designed to meet the clinical situation, customizable to each provider. As a hospitalist, I may receive 100 messages per shift and don't need frequent reminders as I'm checking messages often. A STEMI requires an aggressive notification protocol to ensure timely response. But after several notifications and no acknowledgement, there must be smart escalation or redirection of the message via a backup process. The group designs their backup plan, and in the event a care team member or provider doesn't pick up a message, there's a prescriptive process in place that doesn't require the originator to continue to seek the next step and try to figure out who to contact. The ability to audit these notifications and subsequent escalations is key to a risk mitigation strategy. Finally, the solution must have the flexibility to span all of the recipient's preferences. If a physician loves their pager, there shouldn't be a separate process or solution. Rather, the technology must be encompassing enough to address that scenario. In this picture, you can see examples of ways communications may be initiated via hospital systems, clinicians, or providers out in the community, as well as patients. Each of those communications is processed via dynamic intelligent routing and is sent out via the recipient's preference, whether it be call, message, page, or text. Real-time calls provide caller ID anonymity and a backup step should the recipient not answer. Secure messages can be accessed via a mobile application, web, or by calling into the secured inbox with authentication. Messaging sent to pagers and SMS text are screened for PHI, and those fields are filtered automatically. Your page will still include the callback name, the number, and the reason for the message, but the patient-specific information is removed in order to maintain HIPAA compliance. As technology continues to grow, new devices become available, and it's imperative that solutions be accommodating of clients' evaluations and choice of mobile device. Here you can see not only an Android and iOS device, but the SpectraLink Pivot, Cisco 7925 VoIP phone, the Motorola MC40, and the Ascom Myco device. Several of these are emerging nurse-provisioned smartphone devices, purpose-built with technologies needed in the bedside care team space. All these devices become increasingly popular. It's reasonable that hospitals may want to try more than one, so it's necessary that solutions support any option as the investment may be substantial. Again, flexibility and customization. In summary, healthcare solutions or healthcare communications provide great challenges, but the right solution can lead to tremendous benefits for every care team member as well as the organization. The solution must be comprehensive, providing standardization and the ability to streamline the communications process. Dynamic intelligent routing is essential to addressing complexities and driving sustained adoption. Integration capabilities can incorporate existing legacy systems to provide a more robust and efficient process. Ensuring messages are acknowledged and having the analytics to reflect the interaction is vital. And these criteria will ensure that you are successful in addressing the obstacles in clinical communications and having a correlating improvement in both physician, care team, and patient experience. And at this time, we'll entertain questions.
Great. Well, Julie, thank you so much for such an informative webinar, and thank you for sharing all your good experiences with our audience today. There's a couple of questions already in the Q&A box, and I'll invite anybody who's on the call to ask additional questions if you should have any. Let me go ahead and start with the first question here. It comes from Kyle. Kyle says, you mentioned this was the last of the series. Where can I access the other webinar? That's a great question, Kyle. We actually have them posted already on our website. If you go to PerfectServe.com and visit our Knowledge Center, you'll see an opportunity to look at all the content we have, and there's an area entitled Events and Webinars, and you can go right there to click our webinars on demand when it's convenient for you or any of your colleagues to access. The second question that's in the chat box comes from Sawyer, and Sawyer is asking what type of hardware and software is needed in order to deploy PerfectServe. Julie, can you take this one?
Absolutely, Carrie. So PerfectServe is actually a cloud-based hosted solution, so it requires minimal IT infrastructure or engagement, which makes it very simple and easy to deploy, and also is key in allowing the solution to span across the care continuum and not just be confined within the walls of the hospital. So as I mentioned, PerfectServe can be accessed via a landline phone, which may be set up as a telecom extension. It may be accessed via the web through a common or modern web browser. And it's also available via native applications on iOS and Android devices. So there's really no specific hardware or software that will need to be acquired.
Well, that's great to know. Thank you so much. We have another question coming from Lisa, and she asks, what type of solutions do you find most helpful in engaging your PCPs?
That's a great question. Again, as we see solutions in the market that specifically solve communications within the four walls of the hospital, we also see trends where primary care providers are infrequently coming into the hospital and are more likely sending their patients in, and they're being covered by hospitalist groups or residency programs. It's important to keep the primary care provider engaged in the care cycle for a patient because, as we know, one of the key measures that hospitals and healthcare systems are looking at are readmission rates. And so there are solutions that are available specifically to notify primary care providers when their patients arrive to the emergency department and are registered, and we can, in an automated fashion, actually send out a secure communication to the primary care provider, immediately notifying them that the patient has presented. And in some cases, we have seen this enable the PCP to reach out to the emergency department and give some background on the patient, and that has led to many instances where the patient hasn't been admitted when they might have otherwise been. Additionally, if the patient is discharged home or admitted to the hospital and later discharged home, there is obviously follow-up care that is vital to ensuring that the patient continues to remain stable and healthy and not be readmitted to the hospital. And so again, those automated processes to engaging the primary care provider with what's going on, in the inpatient care realm are essential to care team collaboration across the continuum.
Mhm. And with value-based care, it's really important that organizations minimize as much as they can their reoccurring patients so that they can keep their reimbursement levels high. So that's a great solution. Amber is who the next question comes from, and she asks, do you have any recommendations for deploying a comprehensive solution across a multi-hospital system?
Absolutely. There are always unique challenges when you look at multi-hospital systems. I'm actually at a multi-hospital system currently evaluating their challenges, and there are definitely recommendations on implementation or deployment methodologies, and it's always a very collaborative process when working with the organization and their culture and making those recommendations. But there are a few key things to look at. Obviously, you have different providers that are on staff at different facilities, and it's important when you look at deployment that you provide the most seamless process for those providers that may split between multiple sites, so they're not living in different worlds of communication per se. And so we evaluate those types of things. We also evaluate standardization of processes across systems. So we have the flexibility perhaps to employ one process at one facility and a separate process at another facility. But if there are corporate standards around standardization of processes for other purposes, then we can certainly recommend and deploy in that fashion as well. So there are a lot of areas for operational efficiencies, and it's a very collaborative process to design and deploy based on each unique facility's needs.
That's great information, and as the workforce becomes more and more mobile, and that's really important to have the ability to customize and make things personal, to make the experience good for the physicians as well as the people contacting them. The next question I have for you, Julie, comes from Monica, and Monica's asking about consultants, and she wants to know, do the PerfectServe consultants do process improvement work with groups, or are the current solutions put into the technology already?
Again, a great question. And one of the things that we discuss often is that if we come into an organization and there are broken processes, the last thing that you want to do is lay technology over a broken process, because that's certainly not going to fix the issue. So our consultant teams spend many, many hours working with each individual group in the facility and really educating them on what the opportunities are, not just evaluating their current state and their current process, but enlightening them to what their opportunities are with technology behind them and a comprehensive solution, and oftentimes delighting them by giving them the opportunity to design something that's much more effective for all of the care team members involved in the process.
Well, that's great to know that your team has everybody's back, because an implementation is a great opportunity to really look critically at the workflow and to make things even better than they imagined. So that's a huge win for any facility. We have another question here from Katie, and Katie asked the question, how do you know the workflows and schedules of the providers?
Probably one of the most challenging pieces, and of course every nurse out there asks the same question of themselves every day. But what PerfectServe does in our implementations that's very different than a lot of other organizations or vendors is that we work specifically with each individual group on the medical staff. We engage their administrators, we engage their key leaders in the group, and we discuss their process uniquely with them and help them design all of those pieces of their puzzle. We talk about their schedules. We talk about them having multiple schedules. Some groups I've seen have 30 or 40 different call schedules that have 60 or 70 providers, and they have a lot of different moving parts. So we discuss their schedules. We discuss their processes when certain scenarios occur, and we discuss the optimal outcome for each communication, and then we incorporate those things into the platform so that the nurses and care team members, when interacting with each other and other providers, don't have to do that work, but rather it's at their fingertips built in for them.
Mm-hmm. So again, the dynamic intelligent routing that you spoke of earlier seems to be really key to making that happen. Okay, we have one final question from Terry, and if anyone else has a question, you're welcome to go ahead and include that in the Add Question area of the screen. And Terry asks, how do you engage providers to drive adoption? Do you have any tips and tricks?
Absolutely. So I think the key thing in driving adoption is really whether or not you are solving their problem. We see low adoption with basic secure messaging because it doesn't really solve the issue of knowing who to contact or knowing the best way to reach out to them. And so when you come in with a product that solves the complexities of their communications, you will find that there is an eagerness to adopt because everyone in healthcare from a clinical perspective is living with these complexities each and every day. The other pieces that are important are, again, leading those efforts to educate, so involving yourselves in department meetings, medical executive meetings, care team staff meetings, and educating everyone involved in the process that this is coming, how it's going to benefit them, and the flexibility and the ability to customize and how important those things are to them and what we're bringing to the table. You know, we find that when your solution brings all of those key components to the table, it is not at all an issue to have 85, 90, 95% adoption without really having to fight your way in or, walk door to door to get providers to engage.
Those are amazing statistics. And I guess if you solve their problems, they will use it and be very happy with it. So that's awesome. Okay, at this point in the presentation, I would very much like to thank Julie for doing such an amazing job today, answering everybody's questions. And I also wanted to thank all of you in our audience for joining us today, as well as the other webinars that we offered earlier in the last 6 weeks. I want to close the presentation with one final polling question, and that's just an opportunity for you to let us know if you would like additional information about PerfectServe Synchrony to help your hospital, your practice, or your health system streamline your communications and improve your operational efficiency. And then to close the call, I will ask you also to provide your feedback. We want to make sure that we are offering you the most beneficial and informative webinars in the future. So if you would take a few minutes and complete our short survey letting us know how we did today, we would really appreciate it. Copies of today's slides, as I said earlier, as well as all of our webinars on demand for this Nursing Leadership Series will be available on PerfectServe.net. Please visit the Knowledge Center and you'll find all of our resources there. And at this point, I'll turn it over to our operator.
Thank you, ladies and gentlemen. This concludes today's webinar. Thank you for participating. You may now disconnect. Speakers, please stand by for your